Waalaikumsalam. Yes, Doctor.
Okay. Shall we start our session recitation of Kitab Surat Al-Fatiha? Okay, our topic today is very important topic, but it is it is a very big topic. Therefore, we have to be careful about the time so that we can finish within 2 hours. Okay, so be aware about the time, please. May I know how many presenters? Only 4, or how many of you in group A?
Only 4 of us.
4 only, not 5.
No.
Okay, so you can start.
Okay, Assalamualaikum warahmatullahi wabarakatuh, and good morning, everyone. My name is Muhammad Ali. My name is Muhammad Ali bin Muhammad Asni, and today my friends and I will be presenting the topic drugs and alcohol-related psychiatric disorders. And as the name suggests, there will be 2 main parts in our presentation. The first one is regarding alcohol-related psychiatric disorders, and then we will proceed into the drugs-related psychiatric disorders. Okay, so before we jump into the main topics, there are a few terms that I would like to first define to make it clearer later in the presentations. Okay, so these are the specific terms. The first one is abuse. It is defined as maladaptive patterns of substance use that impair health in a broad sense, causing physical, mental, and also social complications. Intoxication. It is a transient reversible syndrome caused by recent substance ingestion that produces clinically significant psychological and physical impairment. So the affected mental functions are the memory, orientation, mood, judgment, and behavioral, social, and occupational functioning. Dependence. It is a certain physiological and psychological phenomena that is induced by regular substance intake. So dependence may be psychological or physiological. The physical dependence means there is an alteration to the physiologic state of the body due to repeated administration of the drug, resulting in a specific syndrome, meaning that the patient experiences signs and symptoms that we can clearly see. And then for psychological dependence, it is the cognitive and emotional aspects of the addictive behaviors experienced only by the patients. And then we have tolerance. It is a state of decreased effect of a certain drug after repeated administration, and increased doses are required to produce the same effect. The cross tolerance, also known as cross dependence, meaning that it is the inability of one substance to be substituted for another, as they produce the same effect physiologically and psychologically. For example, diazepam and barbiturates. Codependence, it is also known as co-addiction, referring to the family members affected or influencing the addiction behavior of another family member. Another term that is related to codependence is enabler, meaning a person who facilitates the abuser's addictive behavior, such as directly providing drugs or indirectly providing drugs by giving money to buy it. This includes the unwillingness of a family member to accept addiction as a medical psychiatric disorder, or straight up deny the person's addiction to the substance, abuse of substance. Then we have craving. This is a subjective sense of need to consume a particular substance, and may be due to dependence, and also most likely due to dependence. Tolerance, the same as before, a state of decreased effect of certain drug after repeated administration is repeated. And then we have withdrawal. It is also known as abstinence syndrome or discontinuation syndrome. Withdrawal syndrome is a group of signs and symptoms occurring when a drug, which is drug specific, that occurs when a drug or substance is reduced or stopped, lasting for a limited time. It is characterized by physiologic signs and symptoms in addition to psychological changes such as thinking, feelings, and the behavior of the patient. In general, drugs with short half-lives will produce symptoms more rapidly, yet are more transient. And clinically significant withdrawal symptoms occur in dependence on alcohol, opiates, and benzodiazepines, and occasionally in cocaine, cannabis, and amphetamine users. And then the last one is detoxification. It is the process of managing withdrawal from drugs of dependence. This is aided by psychological support from your social circle, the family, the friends, and symptomatic prescribing of drugs or reducing dosage of prescription of the same or similar drugs. So we'll start with our alcohol-related psychiatric disorder. This is the outline for my presentation today. So, alcohol, an introduction. So alcohol, the word alcohol refers to a large group of organic molecules that have hydroxyl group, the OH group, attached to a saturated carbon atom. So consumed alcohol is ethyl alcohol, also called ethanol, one of the most common alcohol. So the alcohol metabolism, there are two steps in alcohol metabolism. There are two steps in alcohol metabolism. The first one, when it is ingested, it will be absorbed in the small intestines, and it will be metabolized in the liver. So ethanol, for example, will be converted into acetaldehyde by alcohol dehydrogenase, and acetaldehyde, which is toxic, is then converted into acetate by aldehyde dehydrogenase. And alcohol intoxication occurs when a person ingests alcohol faster than it can be metabolized. And 90% of consumed alcohol is absorbed by the small intestines and metabolized by the liver, whereas the remaining 10% is absorbed and metabolized in the mucosal lining of the stomach. The peak blood concentration of alcohol is reached between 30 to 90 minutes, depending on whether it is ingested on an empty stomach, which makes it rapid, quicker, or with food, which delays the peak blood concentration of alcohol. Then second is the rate of ingestion. So rapid drinking will reduce the time to peak blood concentration and vice versa. So alcohol, it functions as a depressant, and it's similar to barbiturates to benzodiazepines. Alcohol-related disorders. The definition is a group of medical conditions that are diagnosed when a patient's drinking causes significant harm, concern, or harm, and decrease in life functioning. So generally the clinical presentations that all alcohol-related disorders have is the patient might indulge in binge drinking. They drink a lot within within a short period of time, and the patient will have frequent cravings. There will be negative life consequences directly from drinking, for example, absenteeism from work or classes, breakdown of interpersonal relationships, broken families, unsustainable partners, and then even legal problems, for example, driving under influence, drunk driving. Then the patient might also experience amnestic events or blackouts. They also might have feelings of guilt, remorse, regret, or disgust over drinking, but however unable to reduce the drinking. Then they will there will be also concealment of drinking, meaning they hide the drinking habits from their friends and families. And lastly is withdrawal, whenever there is a cessation of drinking. Those whose drinking has caused alcohol-related disorder or disability, we call it problem drinking. Problem drinkers may or may not be dependent on alcohol. So problem drinking is not the same as alcoholism, but it has already caused an alcohol-related disorder. The different type of drinks of booze have different levels of alcohol, of pure alcohol. So generally, the unit, it is 1 unit. So 1 unit is equal to 8 grams of pure alcohol. So for example, a can of ordinary beer, there is a 1.5 units of alcohol. A can of strong beer, 4 units. A pint of cider, 3 units. A bottle of wine, 4 units. A glass of wine, 1.5 units. And a bottle of spirit, for example, whiskey, gin, brandy, vodka, have 30 units of alcohol in general. So the recommended weekly limit based from the National Health Service UK for both men and women is 14 units of alcohol. Before this, men's limit is higher than women, but lately it is considered the same. And if it is more than 14 units, this is, we can say quantitatively, the patient has problem drinking. The epidemiology of alcohol-related disorder, so globally, the WHO estimates shows that there are over 283 million people afflicted with this problem. And men, and there are more men with this problem with over 5:1 ratio compared to women. And heavy drinking is higher in the late teens and early 20s in the younger populations. And it is also higher in high-income countries due to, you can say that processed alcohol is rather pricey. And then it is the 3rd largest health problem in USA after cancer and after heart disease and cancer. So what causes alcohol-related disorders? From one source, it is cited that at least 60% of all patients with alcohol-related disorders is due to genetic factors. Okay. For example, first-degree relatives, especially first-degree relatives of someone who has a person with drinking problem in their family. For example, their parents. It doubles the risk of alcohol-related problems. In twins, there is a significantly higher rates of alcohol dependence in monozygotic than dizygotic twins. For children of alcoholics, they have higher risk related to the first statement, the first-degree relatives. The children of alcoholics have higher risk of developing alcohol-related problems, even when they are adopted into families without drinking problems. And then we have occupational etiology. the professions with ease of availability to alcohol, for example, industry workers, professions with which enable social drinking, for example, executives, actors, salesmen, and people with stressful job, even doctors, has higher risk for developing alcohol-related disorder. Then psychiatric disorders, patients with depressive and anxiety disorders, for example, social phobia and panic disorders, are more vulnerable to alcoholism. So they believe that alcohol can somehow reduce the symptoms, especially when they are trying to do something. So it may help. Then other psychological factors. So in Western countries, drinking is normal for when you reach for the people when they reach a certain age, right? So it is a learning process that may contribute to the development of alcoholic dependence. When they just start drinking, the repeated experience of withdrawal symptoms and the relief of these symptoms by drinking may reinforce more drinking. So basically they drink and they start having withdrawal symptoms, and the only relief that they can find is by drinking. So it causes more drinking. And then role of modeling or imitation. It is a learn and reinforce behavior in children that may imitate their parents' drinking patterns. Then there is negative coping skills to stress, personality disorders and traits, antisocial and anxious avoidant. Again, the same like I mentioned before. The feelings of isolation and neglect, ego defect, the absence of limitation of ego functions, so they cannot reason properly with what they take, what's right and wrong, so they may indulge in drinking too much. And then finally, traumatic events, grief, loss. This psychological trauma may cause and worsen alcohol-related problems. Then we have social factors, unemployment, easy availability, poor upbringing, environmental stresses, and also cultural celebrations. Then self-efficacy and spirituality. So this one is a protective role in maintaining abstinence and predicts response to treatment in alcohol-dependent patients. These are the specific alcohol-related problems, and I believe we are only going to discuss the psychiatric disorders today. Okay, so the first one is alcohol use disorder. Before we proceed, alcohol use disorder is from the DSM-5. It is divided into two main disorders: alcohol dependence and alcohol abuse. But generally, the diagnostic criteria of alcohol use disorder is when is the presence of a problematic pattern of alcohol use, leading to clinically significant impairment or distress manifested by at least two of these symptoms within 12 months. So number one, alcohol is taken in larger amounts or over a longer period than was intended. Number two, there is a persistent desire or unsuccessful efforts to cut down or control alcohol use. Number three, the patient spends a lot of time in activities necessary to obtain, use, or recover from the effects of alcohol. Number four, there is a craving or strong desire to urge to use alcohol. Number five, recurrent alcohol use resulting in failure to fulfill major role at work, home, or school. Number six, continued alcohol use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. Number seven, important social, occupational, or recreational activities are given up or reduced because of alcohol use. Number eight, recurrent alcohol use in situations in which it is physically hazardous, for example, drunk driving, or operating other machineries when they're working. Number nine, alcohol is continued despite knowledge of having persistent or recurrent physical or psychological problem that is likely to be caused or exacerbated by alcohol. Number 10, tolerance, which is defined by either of the following: a need to markedly increase amounts of alcohol to achieve intoxication, or a markedly diminished effect with continued use the same amount of alcohol. And then the last one is withdrawal, as manifested by either of the following: A, the characteristic withdrawal syndrome, I will go through later, and alcohol or closely related substance such as benzodiazepines that is taken to relieve or avoid withdrawal syndromes. So, I mentioned before, at least 2 out of all the symptoms. So, mild disorder is 2 to 3 symptoms. When patient have 4 to 5 symptoms, it is a moderate disorder, and 6 or more symptoms, it is severe. So under alcohol use disorder, as I mentioned, there is alcohol dependence and alcohol abuse. So alcohol dependence, it is diagnostic when on top of the previous symptoms, the patient has early morning drinking. So the alcohol supply is cut off during the night, and in the morning, they have to drink alcohol right away because they are dependent, right? Then presence of daily drinking with increased tolerance and abstinence leads to withdrawal. Dependent drinks, drinking drinks at regular intervals to relieve or avoid withdrawal symptoms. And they are secretive about the amount consumed, and they drink cheap alcohol to obtain alcohol for least money. And then alcohol abuse is when non-dependent drinking, which continues despite established harm to the physical and mental health secondary to the alcohol consumption. So alcohol withdrawal symptom is defined as a cessation or reduction of alcohol use that was heavy and prolonged, as well as the presence of specific physical or neuropsychiatric symptoms. The onset of alcohol withdrawal symptoms is approximately 8 hours or within 6 to 12 hours of abstinence, and peaks between the 2nd and 3rd day and markedly diminish in 4th or 5th day. The diagnostic criteria for alcohol withdrawal in DSM-5 is there are 4 main criteria. A, there is cessation or reduction of heavy and prolonged alcohol use. 2, B, 2 or more of the following developing within several hours to several days after criterion A. So number 1, autonomic hyperactivity, the patient will sweat and have tachycardic. There will be hand tremors and increased hand tremors. The patient may complain of difficulties in doing fine motor tasks, for example, buttoning the shirts or writing. The patient might experience insomnia. There is nausea and vomiting. The patient might experience transient visual, tactile, or auditory hallucination or illusion. The patient will be agitated. They will have anxiety and grand mal seizures or generalized tonic-clonic seizures. So C, symptoms in criterion B, that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So when the symptoms cause problems to their daily functions. And then D, the symptoms are not due to other general medical condition and are not better explained by other mental health disorder. The table is cut off a little bit at the bottom. Okay. Under alcohol-related disorder, we have delirium tremens, which is also called alcohol withdrawal delirium. This is the severe type of alcohol withdrawal syndrome in patients with history of excessive drinking over several years. So delirium tremens is a medical emergency with a high mortality rate, which is around 15 to 20%. The onset of delirium tremens is approximately 48 hours after last alcohol reduction or abstinence. Delirium tremens can be characterized by clouding of consciousness, reduced consciousness, disorientation of time, place, and impairment of recent memory. Perceptual disturbances, including illusions and hallucinations. Hallucinations and illusions, mainly visual, often showing frightening Lilliputian person or animals, little people, Lilliputian. Auditory and tactile hallucination can also occur. So patient with delirium, they may be dangerous due to the unpredictability of their behavior. So they may act, they may be assaultive or suicidal and may act on hallucinations or delusional thoughts as if they are genuine. They will show severe shouting, fear, and prolonged insomnia. They will have marked autonomic disturbances, including sweating, palpitation, tremor, fever, dilatation of pupils, and hypertension. Dehydration, electrolyte disturbances are characteristic to delirium tremens. And blood test shows leukocytosis with raised ESR and impaired liver function due to long-term drinking. And delirium tremens usually last 3 to 4 days and often ends in the inpatient. For patients, often ends in deep and prolonged sleep, from which the person awakes with little to no memory of what happened during the delirious state. So basically, they just have retrograde amnesia for the last for all the ruckus that they have made. Since it is emergency, the management of since it has a very high mortality rate, the management of delirium tremens will need an emergency medical inpatient care that includes number 1, close monitoring of vital signs every 6 hours. Then we have to correct any imbalance, any electrolyte imbalance. Put the patient in bed rest in an isolated room to reduce the sensory stimulation and restrict visitors from the patient. Reduce symptoms using sedative drugs such as benzodiazepines, chlordiazepine oxide, or diazepam. Administer thiamine to prevent development of Wernicke's encephalopathy and folic acid supplementation. After the patient is stabilized, taper chlordiazepine oxide gradually. Next, alcohol-related disorder is alcohol intoxication. The definition for alcohol intoxication is when there is recent digestion of a sufficient amount of alcohol to produce clinically significant maladaptive behavioral or psychological changes. So the symptoms of alcohol intoxication will vary depending on the blood alcohol concentration or BAC level. So BAC level of 20 to 30 milligram per deciliter, the patient will exhibit slurred motor performance and decreased thinking ability. Between 30 to 80 milligram per deciliter, there will be increased motor and cognitive problems. 80 to 200 milligrams per deciliter, increases in coordination and judgment errors, mood lability, and deterioration in cognition, further deterioration in cognition. And then 200 to 300 milligram per deciliter, we can see nystagmus, marked slurring speech, and alcoholic blackouts. And beyond 300 milligrams per deciliter, BAC, they will have impaired vital signs and possibly death. The diagnostic criteria for alcohol intoxication based on the DSM-5, there are also 4. A, the first one, there must be recent ingestion of alcohol. B, there is clinically significant problematic behavior or physiological changes. For example, the person shows inappropriate sexual or aggressive behavior, mood liability, or impaired judgment, mainly behavior lah, and that developed during or shortly after the alcohol ingestion. B is behavior, and then C is the sign and symptoms that we can see and the patient experience that develops during or shortly after the alcohol use. Number 1, slurred speech. Number 2, incoordination. Number 3, unsteady gait. Number 4, nystagmus. Number 5, impairment in attention or memory. Number 6, stupor or coma. So at least one of these following signs and symptoms. And D, the sign and symptoms are not attributable to another medical condition and are not better explained by another mental disorder, including intoxication with another substance that may show the same symptoms. So that's all from me. Is there any question before we proceed with our next presentation? Presenter.
Okay, thank you, Brother Ali. Any question to the presenter? I think it's very well presented, the topic. So, you know that alcohol withdrawal can be very serious, and also alcohol intoxication. You can see that the level of alcohol withdrawal can be changing from the initial signs and symptoms, starting from after maybe 6 to 12 hours after the last intake, usually happened in patients with heavy alcohol intake for a long period of time. Then the characteristic withdrawal symptoms started with the shake, the first sign. You can see the shaking in the hands, legs, and trunk. Then there will be sometimes become agitated, they cannot restless, unable to sit still, and the nausea, vomiting. When these patients taking alcohol, all these symptoms were relieved. That's why most of alcoholic patients, they are aware of all these withdrawal symptoms. So the first thing they will take is when they wake up in the morning, they will take alcohol, because the alcohol blood concentration will fall during the sleep. So that's what we call eye opener. And then when the progression of these withdrawal symptoms, there will be some psychotic features, there will be hallucinations, there will be illusions, and then maybe have fit, what we call trump fit, which is tonic-clonic generalized seizures. And then the most serious one is delirium tremens, as presented, which is may considered as emergency because of the high mortality rate from 15 to 20%. And then the kind of features of delirium will be there, cognitive consciousness, perceptual disturbances, and dehydration, electrolyte disturbances. And these symptoms are fluctuating during the day, being worse at night. And then it lasts for 3 to 4 days and will be subsided. Maybe the patient will wake up with not remembering about the period of the withdrawal. And treatment is very important, as mentioned by the presenter. So usually we treated with monitor the vital signs, and then the correction of any electrolyte imbalance, and then we have to optimize the sensory, meaning that we avoid stimulation and not reduce to the degree that become very dark room. No, it should be optimized. And then we have to give benzodiazepines, just long-acting one, diazepam or chlordiazepoxide with a thiamine supplement. And then we taper the dose of the benzodiazepine accordingly after a few days until we stop. Okay. So, any question, or we proceed with the next presenter? Okay, proceed.
Okay, all right. Morning. So I'll proceed with the next. alcohol.
Can you please introduce yourself?
I'm sorry. All right. So the name's Afaf Kemilia. Okay, so I'll present on the next alcohol-related disorder, which is alcohol-induced persisting dementia. It is actually a long-term cognitive problem that can develop in the course of alcoholism. So it is characterized by global decreases in intellectual functioning, cognitive abilities, and even the memory of the patients. So it was found that the brain function tends to improve with abstinence, but then perhaps with half of the affected patients have long-term and even permanent disabilities in their memory and thinking. So it was approximated around 50 to 70% of these patients to which they had evidences of increased size of their brain ventricles and even the shrinkage of the cerebral sulci. Although these changes actually appear to be partially or completely reversible during the first year of complete abstinence. All right, next is on the next slide is on alcohol-induced persisting amnestic disorder. All right. To which it is, as compared to the previous one, it is actually a disturbance in short-term memory, also caused by the prolonged heavy use of alcohol. So the classic names for this disorder is Wernicke's encephalopathy, which is a set of acute symptoms, and Korsakoff syndrome, which is a chronic condition. So Wernicke's and Korsakoff are believed to be pathophysiologically related. So the connection between these two syndromes is thiamine deficiency, to which it might be caused by either poor nutritional habits or malabsorption problems. So for Wernicke's encephalopathy, it is actually an acute neurological disorder, which is characterized by ataxia, which is gait problems, confusion, and ocular motility abnormalities, for example, nystagmus. So it may clear spontaneously within a few days or weeks, or it may actually progress into Korsakoff syndrome. So the treatment for Wernicke's encephalopathy is urgent treatment in medical setting, to which it responds rapidly to large doses of parenteral thiamine. So initially, thiamine is administered 100 milligrams intravenously, slowly over 10 minutes, and then they were to be continued to be taken by mouth, 100 milligrams, 2 to 3 times daily for up to 2 weeks. So for Korsakoff syndrome, as mentioned, it is a chronic amnestic syndrome that can actually follow Wernicke's encephalopathy. So the cardinal features of Korsakoff syndrome is impaired mental syndrome, especially recent memory, and anterograde amnesia in alert and responsive patients. So the treatment is again thiamine per oral, 100 milligrams, 2 to 3 times daily, but then it has to be taken for up to a year, 12 months. Right. The next disorder is alcohol-induced psychotic disorder. So on the diagnosis and clinical features of this disorder is, it was approximated that 3% of alcoholic persons actually experience auditory hallucinations or paranoid delusions in the context of heavy drinking or withdrawal. So these auditory hallucinations, they are most commonly in voices, to which these voices are maligning, they are defaming, reproachful, and even threatening. So these hallucinations usually last less than a week, but then during that week, impaired reality testing is common. So after the episode, most patients realize the hallucinatory nature of the symptoms. So these hallucinations, it can occur at any age, but then they usually appear in persons abusing alcohol for a long time. So alcohol hallucinosis, it is actually a substance-induced psychotic illness, which is a rare complication of prolonged heavy alcohol abuse. So the sufferer actually experiences hallucinations, which is auditory in nature, while the patients are in clear consciousness and while they are sober. So when patient experiences these symptoms, they usually appear anxious and restless. So the treatment is pretty much like the treatment of delirium tremens as mentioned before, which is to prescribe with benzodiazepines, and then to provide them with adequate nutrition and fluids if deemed necessary. But then say if this regimen fails, or for long-term cases, antipsychotics may actually be used. So when it comes to hallucinations, we have to differentiate between alcohol withdrawal related hallucinations from other diagnoses with hallucinations. So first we have alcohol withdrawal related hallucinations to be differentiated from the hallucinations of schizophrenia by these three characteristics. So the first is the temporal association with alcohol withdrawal. A second, the absence of a classic history of schizophrenia. And the last one is the hallucinations for alcohol withdrawal related is usually of short-lived duration. Another one that we have to differentiate is alcohol withdrawal related hallucinations from the delirium tremens, to which it happened during the presence of a clear sensorium in patients, as compared to delirium tremens if the patient are delirious. All right. The next, this is the DSM-5 criteria for substance or medication-induced psychotic disorder, to which criterion A stated that the presence of one or both of the following symptoms, either delusions or hallucinations. Criterion B mentioned that there is evidence from the history, physical examination, or laboratory findings of both 1 and 2, to which number 1, the symptoms in criterion A develop during or soon after substance intoxication or withdrawal, to which in this case, alcohol. Number 2, the involved substance or medication is capable of producing the symptoms in criterion A, which is either the delusions or hallucinations. Criterion C, on the other hand, it stated that the disturbances that they experience, that the patient experienced, actually is not explained by any other psychotic disorder that is not substance or medication induced. All right, next is criterion D, okay, which is it's mentioned that the disturbance does not occur exclusively during the course of a delirium. And the last one is, which is E, the disturbance causes clinically significant impairment in patients, be it in social, occupational, or other important areas of functioning. So it is also important for us to specify whether the onset of the symptoms happen during the intoxication or during the withdrawal. Right. Next, alcohol-related disorder is on mood and anxiety disorders, alcohol-induced. So it is frequently reported in alcohol abuse, in alcohol abusers to have symptoms such as generalized anxiety, panic attacks, and low moods. To which these symptoms are markedly improved within days of alcohol abstinence. All right. Another alcohol-related disorder is alcohol-induced sexual dysfunction. Yes, okay. To which the distressing sexual dysfunction occurs soon after significant substance intoxication or withdrawal. So, for example, prolonged erection without ejaculation, to which eventually a gradual loss of erectile capability happens in males. All right. Next is on alcohol-induced sleep disorders. So typically it occurs as the insomnia type. So in acute intoxication, there will be increased wakefulness in the abusers. But then eventually, even if they were to have some sleep, it will be a restless sleep. And then during alcohol withdrawal, abusers tend to have their sleep continuity to be disrupted. Okay, all right. Next is on unspecified alcohol-related disorder. So the name in itself is pretty much clear. So basically, patients or abusers, they have presentations to which the symptoms are characteristic of an alcohol-related disorder, to which that causes a clinically significant impairment in their life. But then the symptoms do not meet the full criteria for other diagnosis, for example, alcohol-induced psychotic disorder. And the last one for alcohol-related disorder is idiosyncratic alcohol intoxication. So it's defined as a severe behavioral syndrome that develops rapidly after a person consumes a small amount of alcohol that would usually have minimal effects on most persons. So as compared to the previous ones, to which they are chronic heavy abuses of alcohol. This one happened in persons who took only a small amount of alcohol to actually have this severe behavioral syndrome. So users are usually confused and disoriented. And then they tend to have illusions, delusions, and even hallucinations. So this condition usually lasts for a few hours, but then it terminates in prolonged sleep, to which the affected person cannot even recall the episodes once they woke up. Right. So that's on the alcohol-related alcohol-related disorders. The next one is on neurological and medical complications of alcohol use. So So this is a list. So we actually highlighted several conditions actually. So first is peripheral neuropathy. Next we have central pontine myelinolysis. Okay, and then we also have fetal alcohol syndrome. Next slide, please. Okay, all right, so yeah, and on medical complications, we have liver diseases, for example, hepatitis, liver cirrhosis, hepatocellular carcinoma, HCC. And then, of course, we have complications due to cardiovascular diseases, for example, cardiomyopathy, and eventually we also have hematological disorders, for example, anemia and thrombocytopenia. Okay.
Sorry, is the slide not moving? Because I'm in the management part already.
Yeah, sorry. My line is quite slow actually, so I haven't tak keluar management lagi.
What about the others? Can you see the slide?
Yes, I can see.
I only can see management. There's nothing else. Just management.
Okay.
Okay, it's okay. All right. All right. So this is the last few parts to which on management. So of course, early detection and screening for alcohol use problems is of utmost importance, to which the problem with alcohol misuse might actually go undetected because patients conceal the extent of their drinking. And then the fact that they are actually concealing the fact that they are drinking is a problem as well. So the simplest screening is to actually ask the patient how much they drink per week, and then we try to calculate the units that they had consumed. So there are several screening questionnaires that can be used. So the first one is the CAGE questionnaire. So it can be used to identify problem drinkers. So basically the CAGE have different meanings to them. So C is on cutting down. So the questions that we can use to ask the patient is basically, have they ever thought or felt that they need to cut down their drinking? A is for annoyed, to which basically we ask, have they felt annoyed when people criticizes their drinking? G is for guilt. So have they ever felt guilty for their drinking? And last one is E, eye opener, which is, have they ever had a drink first thing in the morning as an eye opener to steady their nerves? So one positive reply for this questionnaire would inquire more on a person's drinking. So we have to indulge more on their drinking habits. But then see if they have 2 or more positive replies, it might indicate alcohol misuse. So the next questionnaire that can be used is the Alcohol Use Disorder Identification Test, or the audit questionnaire. So it is actually a 10-item screening tool that is developed by the WHO. So it's designed to screen for both currently harmful and potentially hazardous drinking, and in a way it can even identify alcohol dependence. So this questionnaire, it can be administered by as oral interview or even a self-report questionnaire. So the total scores for this questionnaire is 40, to which if a person scored between 8 to 15, a brief intervention is needed. And of course, it's based on the risk to develop the alcohol-related harm. And then say if a person actually scored between 16 to 19, a brief intervention is needed, along with regular monitoring. And then if someone scored more than 20, up to 40, basically an early specialist referral is warranted, and also community or inpatient detoxification. But then again, all this depends on the severity of physical dependence. Okay. Next is the high risk group for alcohol problems. I believe that the previous presenter already highlighted this high risk group. So in general, those who are having problems with their primary relationships, for example, problems with their family, their spouses, or problems at work with finances and the law, and also those who are actually involved in high-risk occupations, for example, chefs, bartenders, brewery workers, actors and entertainers, and such. So medically, the physical disorders usually are complications of long-term alcohol abuse, for example, gastritis, peptic ulcer, liver diseases. And then, of course, we have psychiatric disorders, which is pretty much predispose them to actually having alcohol problems, for example, anxiety and depression. All right. So the first one is on screening and detection. The next one, number 2, is on assessment. So, of course, it is important to acquire full detailed history of the patient, not only of the patient themselves, but also the drinking history of the patient, to which we can ask of what do they drink and how much the patient actually drinks throughout a typical day. So we can ask them to describe a typical day's drinking and what time is usually the first drink of the day. And then it's also important to assess the features of dependence and see the range of physical, psychological, and social problems associated with the dependence. So the question that we can use to ask is basically how they feel going on for a day or two without having a drink. The next one is on duration of alcohol problems. So when did the daily drinking actually start, and the first time patients actually experience withdrawal symptoms. And then it's also important to ask them on their past attempts at treatment, for example, the periods of abstinence that they had so far, and the factors that actually help to maintain that particular state of affairs. And then say if the past attempts actually failed, so we need to ask what actually led to the resumption of drinking. And then the patient's own view of their drinking behavior is also important to be asked. And also we have to assess the comorbidity and high risk of the patient, for example, screening for depression or anxiety disorder. So for physical examination, we have to look for the signs that of the harm that is already being caused by the alcohol. For example, liver diseases, malnutrition, neurological signs, and problems with cognition. The last one is on laboratory tests. So other than doing liver function test or LFT to look for signs for liver injuries by looking at the AST and ALT, there are actually also several tests that can be done for alcohol dependence. The first presenter actually mentioned BAC, or breath alcohol concentration, to which it is actually the most direct measure of alcohol dependence. But then it did not distinguish between a single recent episode of heavy drinking or chronic abuse. The next one is gamma glutamyl transpeptidase, or GGT. It's the most useful screening test, to which it showed an increase in almost 70% of alcohol misuses. The third one is mean corpuscular volume, or MCV. So again, there's an increase in people with alcohol problems, and then it takes several weeks to for the value to return to normal after abstinence. And the last one, carbohydrate deficient transferrin. So it shows an increase in response to heavy drinking, and it is actually more specific as compared to GGT. Right. So that's on the assessment. Number 3 is on the motivational interviewing. Right, so we all know that an appropriate interviewing style actually helps persuade patients to engage in a useful review of their current pattern of drinking. So the aim of motivational interviewing is basically to persuade patients to argue their own case for changing their pattern of substance use. So it is actually a less directive approach to which the patient is helped to assess the balance of the positive and negative effects of alcohol in their life. So the clinician mainly helps by providing feedbacks to the patient on the personal risk that alcohol poses to both the patient and their family. And then they also have to come up with numbers of options for change for the patients. All right. Number 4 is on detoxification. So it is a medical management of withdrawal symptoms in patients with substance dependence. So when a patient is dependent of alcohol, actually had this sudden cessation of drinking, so it will eventually lead to severe withdrawal symptoms. So detoxification involves daily assessment under medical supervision. So the treatment is basically a combination of long-acting benzodiazepines and also vitamin supplements, to which the benzodiazepines actually acts to reduce the risk of seizures, delirium tremens, and even decreases symptoms that occur during withdrawal, like craving, tremor, anxiety, insomnia, and also nausea. All right. The 5th point under management is basically maintenance interventions in alcohol misuse. So the first one we have is under psychological methods. So we have psychoeducation. So it is vital actually to provide information and advice to patients on the effects of excessive drinking. By this time, patients usually understand and acknowledge the fact, the impact that alcohol already had on themselves and their family. So clinicians were to explain the options of treatment that a patient have. And then it is also their role to actually encourage family members to participate in such treatment. Right. The next one is on cognitive behavioral therapy, or CBT. So we, as you can see, there are several. So for example, we have social behavior and network therapy. So the use of, it's basically the use of users' social network to help modify their drinking. And then we have behavioral self-control training. So it mainly focuses on controlled drinking rather than achieving abstinence. And then we have coping and social skills training on improving their relationships and how to deal with the stresses in their life. And also we have relapse prevention, to which the patients are taught on how to identify situational or interpersonal triggers, and even rehearse methods to cope with such situations. All right, and next is group therapy. So when it comes to group therapy, it helps patients to maintain a high level of motivation for abstinence and also to enhance their functioning. So in group therapy, they explore the consequences of drinking, the likely future cause of alcohol-related life problems, and also the marked improvement that can be expected with abstinence. So it is to be offered a minimum of 3 times per week for the first 2 to 4 weeks, and then eventually it can be up. It can go on to once a month, but it depends on how a patient improves. All right, the next one is on rehabilitation. So again, it's basically a continued effort in order to increase and maintain the high levels of motivation for abstinence. So it also works to help the patient in readjusting their lifestyle free of alcohol, and also for relapse prevention. And the last one is group support. So we have example of self-help group, for example, Alcoholics Anonymous, the AA groups. So it's the most widespread of the voluntary self-help organizations for problem drinkers. All right. So so the first one we have is on psychological methods. The second is on medications. So we have two different groups of medications. The first is on alcohol sensitizing agent. Example is disulfiram. So how it works is basically it blocks oxidation of alcohol so that acetaldehyde accumulates in the blood. And then when the abusers actually had alcohol after they took disulfiram, it actually precipitates in this uncomfortable physical reaction, for example, nausea, vomiting, palpitations, flushing. So some patients actually find it useful by taking this disulfiram because the anticipation of these unpleasant reactions actually acts as an inhibitor to their impulsive drinking. Right. The next group of medication is the anti-craving drugs. So we have two types. We have acamprosate and naltrexone. So in acamprosate, it stimulates the GABA inhibitory neurotransmission, to which it leads to the decrease in the excitatory effects of glutamate. So basically, it suppresses the urge to drink in a patient. Naltrexone, on the other hand, is an opioid antagonist, to which it inhibits the action of endogenous endorphins released when drinking alcohol. So basically, it blocks some of the effects of alcohol, and then it also reduces the craving in patients. And then studies also showed that there is a decrease in likelihood of relapse when patients who are in abstinence phase taking naltrexone. All right. Next is on prognosis. This is the last slide for alcohol-related psychiatric disorder, to which it is shown to be favorable if the problem is detected at early stages, when patient actually came to seek treatment once they realized that they had problems with it. And then also it is favorable if patient actually has good insight of the nature of the problems, as in they acknowledge the fact that they are actually having alcohol use problem. And of course, the absence of persisting and psychiatric disorder like antisocial personality disorder or any other diagnosis of other substance abuse or dependence. And of course, the evidence of general life stability, for example, like having a job, good family contacts, relationships, and the absence of legal problems is also contributing to the favorable prognosis. And eventually, when it is favorable, when the patient actually stays for the full course of the initial rehabilitation, which is the first 2 to 4 weeks. That's it from us under alcohol. So is there any questions?
Okay, thank you, Mrs. Afa, for your nice and very well presentation. Anybody has any question before giving my question? Okay. Can the presenter tell me about the spiritual aspect in the etiology and the management, in the effect of alcohol, how it can affect or damage the social and spiritual aspect? Any idea? And this one applicable also for not only alcohol, for the drugs in general, including alcohol. Anybody has any input? Not necessarily the presenter.
May I answer that?
Yes.
May I try,
Ali.
please?
Yeah.
Okay. Okay, so for the spiritual aspect of alcohol and alcohol use disorder, certain religions, for example, Islam does not allow, basically it is haram, illegal to drink, to ingest alcohol. So, and any violation will be met with severe punishment, right? So it serves as a like a deterrent to drinking, and it may prevent someone from drinking. It has a protective role. So when it comes to treatment, it is also very helpful. especially when a person is trying to get to repent, to get back into their old Islam life. So the prognosis also depends on the spirituality. Or we can say that spirituality have a significance in the outcome of the treatment. So that's all.
Okay, thank you very much. Very well explained, because the spirituality plays an important role in the management of patients with with alcohol-related problem. Because initially, when also it's applicable, as I mentioned, to any other drugs. Because those people initially, when they start, they may have, they use the drug to relieve or to gain some relief about some stressful situations. So they begin to have habitual use of that lead to addiction. In fact, they have difficulty with, with Iman and Tawakkul, because they don't rely to Allah subhanahu wa ta'ala to cope with their problems. While in fact they rely to the drugs. That's why we need to break this cycle that is affect their spirituality. So recovery is only possible when they acknowledge their inability to self-correct without spiritual force to guide them towards their problem, and recovery only by turning to Allah subhanahu wa ta'ala for guidance and help. This is very important because, the alcohol can affect also their ibadat. It affects the abounding, the Islamic upbringing. They affect the character, akhlaq. They affect gratitude to Allah subhanahu wa ta'ala. That's why we have to do intervention from the biopsychosocial spiritual aspect. Okay. Thank you very much for the both presenters. Good presentation. If there is no any question, we go to the second topic, which is drug-related psychiatric disorder.
Okay, so Assalamualaikum warahmatullahi wabarakatuh. So I will continue the presentation with the drugs-related psychiatric disorders. Slide. Okay, so these are the outlines for the drug-related psychiatric disorders, where we are going to discuss about the cannabis, opioid, stimulants, hallucinogen, inhalant, sedative, hypnotic or anxiolytic drugs, caffeine, and also a little bit about the drug rehabilitation. Next. Okay, so before I further explain about the drug-related disorders, I would like to give a summary regarding how does drug addiction occur. So when a person take abuse drugs, these drugs can act as a positive reinforcer, which can cause the activation of our physiological reward system. So when this occur, it will cause the increase in the frequency of the behavior that will activate the physiological reward system, and this will cause the person to have addiction to certain drugs. Okay, so for the risk factors, the first risk factor for the drug-related psychiatric disorder is gender. So male is higher risk to abuse drugs. This correlates with the statistics of drug abuse, such as cocaine abuse and also cocaine and cannabis abuse, where male is more common than female. Okay, then next, the second risk factor is the underlying psychiatric disorders such as anxiety and depression. The third risk factors is the family history of drugs misuse. This is because when a patient have family history of drugs misuse, the patient may be exposed to the drugs earlier compared to other persons. And the fourth risk factor is easy access to the drugs, such as there are the presence of street drugs or prescribed drugs, such as in patients who have chronic illness. So they and were prescribed with opioids, they are also at higher risk to develop opioid abuse. And the fifth risk factors is the social environment, where peer pressure and also social deprivation. For those who are unemployed and homeless, they are also at higher risk to develop drug misuse. And the last risk factors is the personal history, where patient who has personal history of poor school record and delinquency is at higher risk to develop drug abuse. Okay, next. So first, moving on to the cannabis-related disorder. Next. Okay, so a little bit of introduction. Cannabis, or also known as marijuana or weed, it is the most common illegal drugs used in the world, misused in this world. So it is prepared from a plant as Cannabis sativa. And how does cannabis works? It actually will cannabis will bind to the cannabinoid receptor, and then it will prevent the release of neurotransmitter from the neurons. Okay, as for the epidemiology, according to the NSDUH at 2012, around 90 million persons aged 12 years and above had used marijuana in the past month, and 2.4 million started to use within the last years. And majority of these drugs users actually start to use the drugs before the age of 18 years old. So this shows that higher prevalence is among the adolescents. And as for the gender, male is actually more common than female, where there are twice the rate is higher. The male is more common than female. Okay, next. Okay, so I will discuss about the clinical features and diagnostic criteria based on the DSM-5. Next. Okay, so for cannabis-related psychiatric disorder, I will discuss about the cannabis use disorder, cannabis intoxication, cannabis withdrawal, cannabis-induced psychotic disorder, and also cannabis-induced anxiety disorder. Okay, so for the first one is cannabis use disorder. This is the diagnostic criteria based on the DSM-5. Actually, for the diagnostic criteria, it is the same as the alcohol related disorder, alcohol use disorder. So this is basically the repetition. Okay, next. For the cannabis intoxication, so these are some of the clinical features of cannabis intoxication. So the clinical features, as you can see, it comprises of the physiological symptoms, behavioral symptoms, and also the cognitive symptoms. Okay, next. Okay, so these are the diagnostic criteria. Again, it is quite similar to the alcohol intoxication for the Criterion A, where the person must have recent use of cannabis, but for the criteria B and C, it is different. Okay, so for the criteria B, the patient clinically significant problematic behavioral or psychological changes such as impaired motor coordination, euphoria, anxiety, sensation of slow time, impaired judgment, social withdrawal that develop during or shortly after the cannabis use. And then for the criterion C, it is related to the signs and symptoms of cannabis intoxication, where the person must have 2 or more of these symptoms within 2 hours of the cannabis use. The symptoms include conjunctival injection, increase in appetite, dry mouth, and tachycardia. Next. And of course, this is the same like alcohol intoxication. All of these symptoms is not attributable to any other underlying medical condition or any other mental disorders. Moving on to the third one, which is the cannabis withdrawal. So this again is the clinical features of cannabis withdrawal. Next. Okay, so as you can see, again, the criterion A is the same. Cessation of cannabis use that has been heavy and prolonged. And then for the criterion B, 3 or more of the following sign and symptoms develop within approximately 1 week after the criterion A. So these are the signs and symptoms of the cannabis withdrawal. So we must have 3 or more of these symptoms. So the symptoms include irritability, anger or aggression, nervousness or anxiety, sleep difficulty such as insomnia or having disturbing dreams, decrease in appetite or having weight loss, restlessness, depressed mood, and have at least one of the physical symptoms that can cause significant discomfort, such as abdominal pain, shakiness, tremor, sweating, fever, chills, or headache. And for the criterion C, the sign and symptom which will cause clinically significant distress or impairment to the patient. And also, again, the sign and symptoms are not attributable to any other underlying medical condition or psychiatric illness. Okay, so for the fourth one, this is cannabis-induced psychotic disorder. So patient might be presented with delusion or hallucinations or any psychotic features because of the use of cannabis. It's just the same diagnostic criteria because it is under substance-induced psychotic disorder. Next. And this for the cannabis-induced anxiety disorder, patient is having panic attack or anxiety or any other features of anxiety disorders. And yeah, the diagnostic criteria is also the same with alcohol. Okay, next. Okay, so for the treatment and rehabilitation, just like for any other drug treatment and rehabilitation, so we need to stick to the principle of abstinence and support. For the abstinence, we can give direct intervention by hospitalizing the patient, or for the outpatient management, we can do careful monitoring by using the urine drug screening. Okay, so next, the is support, where individual, family, group, psychotherapy support is very important. And next is the regarding the education, where we must give proper education to the patient regarding the drug addiction. And for the fourth management is regarding specific pharmacological therapy, where anti-anxiety drug, it may be useful for some patient and it can be a short-term relief for withdrawal symptoms. And for the patient who is who use cannabis with underlying depressive disorder, we can give specific antidepressant treatment. Okay, next. Okay, so the second one is opioid-related disorder. Okay, so for the introduction, opioid is a drug which is widely used in our medical practice and widely used as analgesics. So it will act on opioid receptor, which are the mu receptor, delta receptor, and kappa receptor. So continued opioid misuse, it will cause syndromes of abuse and dependence, and this will further cause the disturbances in mood, behavior, and also cognition. Okay, as for the epidemiology, among all these types of opioid, the most common types of opioid misuse in developed country is heroin. So in US, there are around estimated 600,000 to 800,000 heroin users, while male is more common than female. As for the age, patients start to use the substance at teens and early 20s and will develop opioid dependence at age of 30s and 40s. Next. Okay, so let's look at the clinical features and diagnostic criteria. Again, I will explain about the opioid use disorder, intoxication, withdrawal, and induced psychotic, and also opioid-induced anxiety disorder. So opioid use disorder, it is also the same diagnostic criteria, the same as cannabis and also alcohol, where, yeah, this all 11 criteria. Okay, next. Okay, so the second one is opioid intoxication. So these are the clinical features such as altered mood, psychomotor retardation, drowsiness, and so on. So for the diagnostic criteria, okay, so for the criteria A, recent use of opioid, and B, clinically significant problematic behavioral or psychological changes such as initial euphoria followed by apathy. Apathy is mean what is meant by apathy is actually the patient having loss of interest, and then dysphoria, psychomotor agitation or retardation, and impaired judgment that develop during or shortly after the opioid use. And for the criteria C is the pupillary constriction or pupillary dilation due to anorexia from severe overdose. So the patient must have these pupillary symptoms, and also one or more of these sign and of the other sign and symptoms of opioid intoxication, which develop during or shortly after the opioid use. Okay, so other among the sign and symptoms are drowsiness or coma, slurred speech, impairment in attention or memory. Next. And of course, again, it is not attributable to another medical condition or another mental disorder. Okay, so the third one is opioid withdrawal. So the clinical features include dysphoric mood, insomnia, nausea or vomiting, muscle pain, ache, and so on. Okay, next. Okay, so for the opioid withdrawal, for the criteria A, it is the presence of either of the following: cessation or reduction of opioid use that has been heavy and prolonged, and administration of an opioid antagonist after a period of use. So either of these followings must be present. And then for the criteria B, 3 or more of the following signs and symptoms which develop within minutes to several days after the criteria A present. Okay, so the signs and symptoms include dysphoric mood, nausea, vomiting, muscle ache, lacrimation or rhinorrhea, pupillary erection, piloerection or sweating, diarrhea, yawning, fever, and insomnia. And then these signs and symptoms will cause clinically significant distress or impairment to the patient, and they are not attributable to underlying medical condition or other mental disorder. Okay, next. So these are the, again, the same opioid-induced psychotic disorder, the same diagnostic criteria. Okay, next. Okay, so for the treatment and rehabilitation, as for the management of opioid overdose in acute setting, first we must do the ABCD management, and then naloxone can be given, which is opioid antagonist. Okay, so the next treatment is medically supervised withdrawal and detoxification, where we will use opioids to treat with opioid withdrawal. So among the type of opioid that we use is methadone, which is a synthetic opioid and are taken orally, and it is daily dosing. So the aim of this treatment is to replace the usual abuse drugs and also to suppress the withdrawal symptoms. So we also need to do methadone maintenance until the patient is used to it and withdrawn from it. Okay, so for the advantages of the methadone therapy is that it will reduce the use of needles, so that therefore it will reduce the HIV transmission, and it produces minimal euphoria and rarely cause drowsiness or depression when used on a long term. And next, it will avoid criminal activity because this methadone is actually available at the clinic kesihatan or primary health center. Okay, so as for the disadvantages, the patient will remains dependent on the opioid. Okay, so for the third treatment is psychotherapy. It is like individual, behavioral, family therapy support group, and we also have a support group like the alcohol support group, which is called Narcotic Anonymous. Okay, and the fourth treatment is Therapeutic Communities, where it is a communities comprised of residents with substance abuse problems, where the rule is abstinence. So the patient entering this community must have a very determined mind to have this abstinence from taking those drugs. Okay, next. This is the methadone. Okay. Okay, so for the third one, it is the stimulants-related disorder. Next. So for the stimulants, I will briefly explain regarding the. Okay, so for the stimulants, these are the examples of the stimulants such as amphetamine and also cocaine. So for the amphetamine, it is a sympathomimetic drugs which use typical amphetamines, where the uses of typical amphetamines will increase performance and induce euphoric feeling. So the amphetamine abuse usually can occur in long distance lorry driver or students who wants to take exam, because this will give them this will cause increase in performance. Okay, so amphetamine, it is the second most widely used substance after the cannabis, and based on the National Survey on Drug Use and Health 2010, around 353,000 persons 12 years or older are the current users of methamphetamine. Okay, as for the cocaine, it is the alkaloid derivative from the erythrosylum coca, where it has high rates of legal, psychiatric, medical, and social problems related to cocaine use. Okay, as for the epidemiology of cocaine use and dependence, in 2012, it is estimated around 1 million persons aged 12 or older is abusing cocaine or depending on cocaine. As for the highest rate of past year cocaine abuse or dependence, the first place goes to patient with age of 8 to 25 years old, and the gender male is more common than female. Next. Okay, so for the clinical features and diagnostic criteria, the first one is stimulants use disorder. So again, this is just a repetition. So this patient must have So the patient must have at least 2 of these following occurring within 12-month period. Okay, next. Okay, so these are the clinical features of the stimulants intoxication. Patient might be presented with sympathetic symptoms such as mydriasis, psychomotor agitation, retardation, perspiration and chills, and so on. Okay, next. Okay, for the diagnostic criteria, they must have recent use of stimulants and be clinically significant problematic behavioral or psychological changes, such as euphoria or affective blunting, changes in social ability, hypervigilance, which is a state where the patient become extremely conscious about their surrounding, and the interpersonal sensitivity, anxiety, tension, or anger, stereotype behaviors, impaired judgment that develop during or shortly after the stimulant use. So for the science criteria C, the patient should have 2 or more the following signs and symptoms of stimulant intoxication, which develop during or shortly after the stimulant use. The signs and symptoms include tachycardia or bradycardia, pupillary dilation, elevated or lowered blood pressure, perspiration or chills, nausea or vomiting, evidence of weight loss, psychomotor agitation or retardation, muscular weakness, respiratory depression, chest pain or cardiac arrhythmia, and the last one is confusion, seizure, dyskinesia, dystonia, or coma. And all of these symptoms is not attributable to any underlying medical conditions and other psychiatric illnesses. Okay, for the third one is the stimulants withdrawal. So these are the symptoms of stimulants withdrawal. So the clinical features include anxiety, dysphoric mood, nightmares, and others. And these symptoms peak in 2 to 4 days and usually resolve a week after that. Okay, so for the diagnostic criteria. Okay, so for the stimulants withdrawal, criteria A, cessation or reduction of prolonged stimulant use. And for the criteria B, dysphoric mood and 2 or more of the following physiological changes that occur within few hours to several days after the criterion A. So the signs and symptoms include fatigue, vivid unpleasant dreams, insomnia or hyperinsomnia, decreased appetite, psychomotor retardation or agitation, And then for the criteria C, the signs and symptoms will cause clinically significant distress or impairment and not attributable to any other medical condition or any other psychiatric illnesses. Okay, next. And these are the stimulants induced psychotic disorder. disorder. Next. Next slide. Hello. Next slide.
Tak nampak ke? Can you see the slide?
Nampak tapi dekat stimulus induced psychotic. Okay,
Excuse me, can we take a break for just 5 minutes?
Oh, okay.
Okay. Okay, thank you very much. Can we start?
Okay, Doctor. Okay, so for this is the stimulants-induced anxiety disorder. It's just the same criteria. Okay, next. Okay, so for the treatment and rehabilitation of the stimulants-related psychiatric disorder, as for the amphetamine, if the patient have used amphetamine and have induced psychotic, we can give antipsychotic. If the patient have an induced anxiety, we can give anxiolytic. If the patient doesn't have any psychosis, we can give diazepam to treat agitation and also hyperactivity. As for the cocaine, we can do detoxification. However, no pharmacological agent is reliable to help in reducing the intensity of cocaine withdrawal. As for the abstinence, we can do complete or partial hospitalization and frequent and scheduled urine monitoring. So actually, the major problem in treating the stimulants-related psychiatric disorder is the drug addiction, because these two drugs can cause very massive, very high addiction to them. Okay, and then the third treatment is the psychosocial therapy involving the individual, family, and group support. So yeah, that's all my part. Thank you.
Okay, thank you, Sister Nadira, for your presentation. Any question? Anybody has any input? Okay, I just want to highlight something regarding the etiology or the of the drugs, the biological aspect. So anybody has any idea about the biological aspect and the etiology? Or the presenter maybe can answer.
For which drug, doctor?
In general.
In general, for the previous presented drug.
All the drugs, meaning that what are the underlying etiology for drug intake, the biological factors, genetic factors, dopamine hypothesis. Do you know about dopamine hypothesis and the etiology of some drugs?
Is it because those drugs will act as positive reinforcer and interact with dopamine pathway, which involve in physiological reward system?
Yes, exactly, because you know that increased dopamine results in increased feeling of happiness and pleasure. So based on this theory of dopamine hypothesis, all the addictive drugs will activate the mesolimbic dopamine system and increase dopamine release or level. So the starting point is the ventral tegmental area. So projects into nucleus accumbens and amygdala and prefrontal cortex. And the addictive powers of these drugs coming from there, stimulating this pathway. So when this pathway is stimulated, this will lead. So the individual that get addicted, those who are genetically with low dopamine activity to begin with. So this genetic factors separate people who will get addicted while other people cannot get addiction. And low dopamine activity, this causes unconscious seeking out dopamine raisers, like for example, drugs or anything that increase the dopamine. And we know that these drugs can increase the dopamine activity, so they get addicted with these drugs. So this may explain. And of course, genetic factors play an important role in the etiology as explained. And the other factors that you mentioned about psychosocial factors will increase the risk, and also some the gender and other social status, and maybe role of modeling and learning theory also, personality disorders diagnosed with antisocial, borderline, problem with ego, and maybe also poor coping mechanisms. Those who are in poor coping mechanism are more prone to have the to be dependent and abusing drugs. Okay, and also I want to highlight about one important thing about methadone replacement therapy, because it's one of the harm reduction program. Initially, is it started to reduce the heroin users used to have IV injection, which increase the risk for hepatitis and that HIV. Therefore, this drug will help because methadone is long acting compared to the heroin, which is short acting. So that's why it will be helpful to reduce the withdrawal symptoms. And also, it's not only that, it includes a rehabilitation program, will help the patient to learn much more proper coping mechanisms. So with time, and also job replacement. So with time, this patient or the addict will be more able to less rely on a drug to overcome stressors, then leading to the abstinence. Okay, I just wanted to explain about the biological aspect. This is very important. Okay, if there is no any other question, we will proceed with the next presenter. Thank you, Najma.
Okay, thank you, Doctor. Is my voice clear?
Yes, clear.
Okay, thank you. Okay, so Bismillahirrahmanirrahim. My name is Nur Amirah Mustafa, and I will present about the fourth subtopic in drug-related disorder, which is hallucinogen-related disorder, which I'll cover about phencyclidine use disorder, intoxication, and also perception disorder. Next. Okay, as for the introduction, as we all know, hallucinogen, meaning the substance that can produce hallucination, right? So the term, beside hallucinogen, the term psychotomimetic is also used. Why? Because the drug can produce the changes that is somewhat similar to the psychotic symptoms. So for example, example of the hallucinogens includes phencyclidine or PCP, and then we also have ecstasy, and then indolamines, for example, like psilocin, and then we have DMT, LSD, which is one type of ergolines. And we need to remember that the mode of action of hallucinogenic drug is actually unclear, but most of them actually act as partial agonists at brain 5-HT2A receptors, which is actually responsible in memory and also cognitive function. So next. Okay, when we mention about phencyclidine, so this is the most important drug in hallucinogen, which is phencyclidine. So when we mention about phencyclidine, it actually includes phencyclidine itself, PCP, and also less potent, but similarly acting in compounds such as ketamine, cyclohexamine, and also diazoxypine. And so as for the introduction, actually phencyclidine was initially developed as a dissociative anesthetic in 1950s like that. But because of the fact that it has this adverse effect of delirium and also hallucination, it was abandoned. So and further become street drugs in 1960s. Next. Okay, and this substance most commonly taken orally or smoked, and they also can be snorted or injected. And we need to remember this, although the primary psychoactive effect of PCP or PCP lasts for a few hours, but the total elimination rate of this drug from the body typically extend for 8 days or even longer. So that's why when we do urine tests, we can still find PCP even after a few days of ingestion. Next. Okay. As for the epidemiology, actually about 2.5% of the population reports having ever used phencyclidine, and out of the proportion, the proportion of the users actually increased with age, whereby it is reported that 0.3% of total population is actually among 12 to 17 years old user, and 1.3% is actually among 18 to 25 years old, and 2.9% is actually among those who age 26 years and also older. Okay, so from here we can see that even younger, meaning that even a person, a children, I would say a children 12 years old already exposed to this use of phencyclidine. And actually, if we look at the emergency case related to PCP, there's about 75% of the reported case are actually males. So we can see that males is predominant in this addiction. Next. Okay, so this is phencyclidine use disorder, one of the disorder, right? Diagnosis criteria. Next. Okay, tekan je sampai habis. Okay, so I think this is just a repetition whereby the use of phencyclidine lead to significant impairment or distress, and they occur within 12 months period, and manifested by at least 2 of these following. Next. Okay, so 2 out of these 10, okay, we can see that if the PCP is taken larger amount or over longer period and etc. So we can suggest that the patient might have this this disorder. Next. Okay, next we have phencyclidine intoxication. Similar to those intoxication disorder, so I will not touch a little bit more about this. I will not explain furthermore. But next, the things that is different is that if within 1 hour, if 2 or more of the following signs and symptoms develop, for example, like vertical or horizontal nystagmus, hypertension or tachycardia, numbness or diminished responsiveness to pain, ataxia, dysarthria, muscle rigidity, seizures, or hyperacusis, or reduced tolerance to sound. So if 2 or more of these following signs and symptoms might suggest this disorder, this intoxication. Okay, so next. Okay, so most commonly, the patient with phencyclidine intoxication actually come with disorientation or confusion, but without hallucination, or next hallucination or delusion, or catatonic like syndrome, as well as the patient might come with coma. Next. Okay, next we have this other disorder, which is hallucinogen persisting perception disorder. Okay, whereby whereby the idea about hallucinogen persisting perception disorder is that after the following cessation, meaning that we have stopped the patient, stop the use of hallucinogen, but then the symptoms, the perceptual symptoms, start to reappear. Okay, that were once experienced while intoxicated with hallucinogen. For example, like next. For example, like geometric hallucination, false perception of movement in peripheral visual fields, flashes of colors, intensified colors, trail of images of moving objects, halos around object, macropsia or micropsia. So one of these following might suggest that disorder. Okay, next. Okay, in terms of management, hallucinogen, for example, like in hallucinogen intoxication, of course, the basic principle in treatment is actually providing reassurance and also supportive care. Okay, by providing a quiet environment or verbal reassurance, so the patient with intense hallucinogen intoxication might feel reassured lah. Okay, and benzodiazepine can also be given in order to speed up the relief for anxiety, and if needed, if we see that the patient might cause danger to themselves or others, so the gentle restraint may be needed. Okay, and then for hallucinogen persisting disorder, of course, we do the palliative treatment. We just give palliative treatment. Pharmacologically, we can give either benzodiazepine or anticonvulsant. For behavioral changes, the patient should avoid over-the-counter drugs, caffeine, and alcohol, as well as physical. Have to avoid physical and also emotional stresses in order to prevent the relapse or this hallucinogen persisting disorder from occur. Next. Okay, so this is the next disorder, which are the inhaler-related disorder, which I'll cover about use disorder and also intoxication. Okay, next. Okay, so for the introduction, inhalant disorder, also called as, inhalant drugs, also called as volatile substance, are actually volatile hydrocarbon that vaporize to gas at room temperature and inhaled, and then it will enter the bloodstream via the transpulmonary route. And these inhalant drugs actually commonly found in many household products and can be further divided into 4 commercial classes. Okay, first one is solvent for glues and adhesive. Second is propellant. For example, used in aerosol paint sprays, and then we have thinners for that used in paint products, and then we have fuels, for example, like gasoline. Okay, next. So the things that we need to remember is that inhalant, even though it seems very tacky, right? Inhalants, but it is associated with numerous of problems. For example, like conduct disorder, mood disorder, can cause suicidal thoughts, and also physical and sexual abuse or neglect. And it also associated with multiple sequelae, meaning that if the patient if the user actually use the inhalant since childhood, okay, it will cause major behavioral and also even organ pathology as a result of drug toxicity. Next. Okay, so for the epidemiology, actually inhalants is very commonly used by poor person and also young person. Why? Because it is easily available, legal, and also inexpensive. So that's why this contribute to the high use among these people. And according to epidemiology, about 6% of people in the US has actually used inhalants. 6%, okay, use inhalants at least one, and 11% of them are actually among young adult age 18 to 25 years old, and 7% had admitted that they use inhalants at least one among the adolescent age 12 to 17 years old, and most users are actually male, which are up to 80%. Next. Okay, so this is the diagnostic criteria. I think I will not discuss more about this. It's just the same, but we need to remember lah. Okay, next. Okay, intoxication diagnostic criteria. It is also the same, except for the 2 or more of the following signs and symptoms develop during or shortly after inhalant use or exposure. If the patient develop 2 or more of the symptoms, for example, like dizziness, nystagmus, incoordination, slurred speech, unsteady gait, lethargy, depressed reflexes, psychomotor retardation, tremor, generalized muscle weakness, blurred vision or diplopia, stupor or coma, or even euphoria. So it might suggest the patient might have inhalant intoxication, provided the patient is recently exposed to this inhalant substance. That's the only difference. Okay, next. Next. Okay, so for the management, of course, reassurance support is very important. And for the the patient's part, the behavioral changes is needed. Okay, to prevent the patient itself from taking the drug again. Okay, and acute cases, of course, will treat it as emergency. Treat it ABCD. You remember, and pay attention to the vital sign and also level of consciousness. Next. Okay, so next is about sedative, hypnotic, and also anxiolytic related disorders. Next. Okay, anxiolytic or sedative hypnotic drugs are indicated in psychiatric due to their calming effects actually. Besides its usage, because of the calming effect, it's also used as anti-epileptic, muscle relaxant, anesthetic, and also anesthetic adjuvants. And there are actually three major group of drugs that associated with the substance-related disorder, which are benzodiazepines, barbiturates, and also barbiturate-like substance. Next. Okay, so these are the classes of drug. Okay, the first one is benzodiazepine, for example, like diazepam, and it is actually this benzodiazepine is actually was introduced in US in 1960s, and during that time, the most prescribed drug is among these classes of drug is actually benzodiazepine, and in Mexico, there's this one drug, one type of benzodiazepine, which is flunitrazepam, which actually become a drug of abuse, and it is illegal in US because why? It is associated with sexual promiscuity and also rape. Okay, the second class of drug is actually barbiturates, for example, like pentobarbital and also secobarbital, which was introduced in US in 1903. After the introduction of benzodiazepam, it has become less prescribed. Why? Because barbiturate has high abuse potential. Why? Because it is very useful and effective sedative. Even though it is very useful and effective sedative, the fact that it is very dangerous because only 10 times the normal dose can lead to death. Okay, and last but not least is barbiturate-like substance, for example, like methaqualone, which oftenly used by youngsters in order to increase the pleasure during sexual activity. Next. Okay, as for the epidemiology, okay, about 6% of the individual has actually reported using sedative illegally, and age group of 26 to 34 years old actually has the highest lifetime prevalence of sedative, which contribute about 3% to 6%. Okay, and among these substance, all the substance related emergency room visits. Okay, so these classes of drugs is actually contributed to 1/4 to 1/3 of all substance. And surprisingly, this kind of drug, this drug, sedative drug, is more common in female compared to male. And usually, people use benzodiazepine together with other drugs. For example, like cocaine user, they use benzodiazepine in order to reduce their withdrawal symptoms. Opioid abuser, they use benzodiazepine in order to enhance the euphoric effect of the opioids. for the other substance abusers, they use these sedative benzodiazepines in order to reduce the anxiety resulted from the use of the substances. Next. Okay, so this is the use sedative, hypnotic, or anxiolytic use disorder diagnostic criteria. But the difference between these diagnostic criteria, use disorder, sedative diagnostic criteria, and apa yang sebelum ni, Phencyclidine doesn't have withdrawal component, but sedative diagnostic criteria have withdrawal component. Next. Okay, so next. Okay, next we discuss about the intoxication, sedative intoxication diagnostic criteria. Again, just the same, except for the one, if there's one or more of the following sign or symptoms developed during or shortly after the usage of the sedative agent. Okay, for example, like slurred speech, incoordination, unsteady gait, nystagmus, impairment, incognition, stupor or coma, provided this sign and symptoms is not associated with other medical condition or mental disorder, we can suggest patient might have this disorder, intoxication. Next. Okay, this is the withdrawal diagnostic criteria. Okay, so okay, for the withdrawal after the cessation of the hypnotic agents, okay, if the patient develop two or more of these following, for example, like autonomic hyperactivity, hand tremors, insomnia, nausea, vomiting, hallucination, psychomotor agitation, anxiety, and also grand mal seizure. So it might suggest the patient might have withdrawal syndrome. Yeah. Next. Okay, so as for management, for example, like benzodiazepine withdrawal, how we treat it? Of course, we start from the history, right? We obtain the drug history and then we do the investigation. We take the urine and also blood sample for drug and also ethanol assay. And then by the guide of history, clinical presentation, and also the result of drug ethanol assay will determine the dose of benzodiazepine. Okay, and then we'll do detoxification from supra-therapeutic dosage. Of course, first hospitalize if indicated, if needed, and then some might suggest to switch to longer acting benzodiazepine, for example, diazepam, or we can actually stabilize on the drug that the patient was taking or on phenobarbital, and then after stabilization, we'll reduce the dosage by 30% on the second or third day, and we will reevaluate the response. Okay, and then we'll reduce the dosage further by 10 to 25% every few days if tolerated. If needed, if necessary, we use adjunctive medication, for example, like carbamazepine, beta-adrenergic receptor antagonist, and others. Okay, even though the efficacy is not established, okay, but we can use it. Okay, and then we have detoxification from therapeutic dosage, where we'll initiate 10 to 25% dose reduction, and we will evaluate the response, where during this time, dose duration of the therapy and also severity of anxiety influence the rate of taper and need for adjunctive medication. So you can read further. Okay, for the long-term therapy, long-term treatment, we can have psychosocial therapy, of course, individual by psychiatrist help, and also support by the community. And it is also suggested that substitution with non-barbiturate, sedative or hypnotist may be used. Okay, but however, the fact that this will cost dependent on another substance cannot be deleted. Okay, next. Okay, so this is the last part of the disorder, caffeine-related disorder. Next. So for the introduction, caffeine, as we all know, is the most widely consumed psychoactive substance in the world, and it is found in more than 60 species of the plants and belong to the methyl-xanthine class of alkaloid. If we remember our chocolate, okay, there's also caffeine, for example, like theobromine found in the chocolate, and also theophylline, remember, used in the treatment of asthma. There's also caffeine in there. And although caffeine is not associated with any life-threatening illnesses, but but the usage can result in psychiatric symptoms and also disorder if not controlled. Okay, and the fact that there's a significant amount of caffeine in our food nowadays, in cocoa, chocolate, and also soft drink, actually it somehow worrying that it can cause this caffeine intoxication in a small children. Okay, next. So this is the caffeine intoxication diagnostic criteria. There are 4 altogether. Okay, and the symptoms, look at the symptoms. If there are 5 or more of the following signs and symptoms develop during or shortly after the caffeine use, for example, like restlessness, nervousness, excitement, insomnia, flush face, diuresis, GI disturbance, muscle twitching, rambling flows of thought, tachycardia, periods of inexhaustibility, psychomotor agitation, provided that these sign and symptoms cause clinical significant distress and not attributable, and not associated with other medical, the other medical condition and also other mental disorder. So we might suggest that the patient have caffeine intoxication. Next. Okay, so next is about caffeine withdrawal diagnostic criteria, whereby first criteria is prolonged daily use of caffeine. Second component is actually abrupt cessation cessation or reduction in caffeine use followed within 24 hours by 3 or more of the following signs and symptoms. For example, like headache, marked fatigue or drowsiness, dysphoric mood, depressed mood or irritability, difficulty concentrating, and having flu-like symptoms, for example, like nausea, vomiting, and also muscle pain, stiffness, might suggest patient might have caffeine withdrawal syndrome. Next. Okay, as for management, of course, we'll treat the patient symptomatically. For example, if the patient have headache and also muscle ache, we'll provide patient with analgesic. For behavioral therapy, whereby at this time we will suggest patient to record the amount of caffeine consumed each day, provided that the patient have to know all the sources of caffeine in the diet, for example, in beverages, in medication, in food even, and then the patient must write in the daily food diary. And after the patient, after written in the daily food diary, the patient will meet us as doctors, right? Meet us, and then we'll suggest patient to how much will reduce the dose of the caffeine. Okay, and remember this, we have to avoid stopping all the caffeine use abruptly. Why? Because there will be development of withdrawal symptoms. Okay. Okay, I'll pass to Nadira Azhari again.
Okay, so before we end our presentation, we will like to do a little bit sharing of drug rehabilitation, where I will explain about the national drug policy, or in Malay we call it as Dasar Dadah Negara, DDN. Okay, so national drug policy use these three basic approaches, which are reduction of drugs offering through law enforcement and cooperation, and then drug demand reduction through preventive education, treatment and rehab, enforcement and international cooperation, and the third one is harm reduction, such for an example, the methadone therapy. Okay, next. So the treatment and rehabilitation, I will focus on the treatment and rehabilitation part. So treatment and rehabilitation aims to help drug addicts to stop searching, compulsive drug use, and eventually abandoning the drug addiction habits. So it has three scopes of services. The first one is about the setting. So there are two settings. The first one is within the institution, and the second one is within the community. Okay, so for the second scope, which is the intensity, so the treatment in treatment and rehabilitation center is individualized, and it will depend on the severity of the drug addicts. Okay, so for the third scope, which is the duration, so the treatment and rehab within the institution will last about at least 6 months, and for the long terms, it will last up to 2 years, while within the community, it will last for 2 to 3 years. Okay, so some of the rehab program available includes the detoxification, assessment and treatment planning, psychosocial and psychospiritual program, and many more. Okay, next. So these are the concept of treatment and rehabilitation. So the first one is varsity of service, where the treatment and rehabilitation service is varied according to the treatment and rehabilitation modality provided. And the second one is the advanced care, where there will be community-based program to promote behavioral changes directly occurring within the community. And for the third one is the interventions. So interventions includes it will first identify the severity of drug addicts, and then starting and continuously in the treatment. And the third one is the therapeutic interventions, and the fourth one is the advanced care management. Okay, so for the fourth concept, the fourth concept is the self-sufficiency development, which includes the family support, social culture support, and also support group. And the fifth concept is the medical treatment. And the sixth concept is the support system, again from the family, recovery partners, and social, because support system is very essential in treatment and rehabilitation of the drug abuse. Okay, next. So this is the National Drug Policy book, so you can get it online and read it for further knowledge. Okay, so I think that's all from our group. Next, these are the list of our references. Yeah, I think that's all. Thank you.
Okay, thank you, Nadira, for your presentation. Any question before we end? I think we're almost past 20 minutes, more than the actual time, but okay, if you have any question. I just want to confirm, according to the list submitted to me, in the group A, supposedly we have 5 students, including Sakina.
Yes, Doctor.
So what's happening? Did you
She was taking the study leave, Doctor.
Oh,
She was on. She is on study leave, sorry.
oh, she's on study leave. Okay, that's why, because I have 5, but 4 presenters. That's why I just want to make sure that there is nobody left. It's okay. Okay, so thank you very much for your very good presentation. You covered the topic very well, all of you. Congratulations. And okay, if there is no question, we end our seminar with the recitation of Surah Al-Asr and Bismillah. Thank you very much. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh.
Thank you,
Thank you,
Doctor.
Doctor.